Thanks for joining. I'm E. David Crawford, Editor-in-Chief of Grand Rounds in Urology. Today, I'm joined by Dr. Dan George, Director of GU-Oncology at the Duke GU Cancer Center and Duke Cancer Institute, as well as my good friend Neal Shore, who's Director of the Carolina Urologic Research Center and Clinical Urologist at the Atlantic Urology Clinics in Myrtle Beach. Neal was a lead author and Dan a co-author on a recent article in New England Journal of Medicine entitled Oral Relugolix for Androgen Deprivation Therapy in Advanced Prostate Cancer. We're anticipating in the next few days that this drug will be approved by the FDA, adding an exciting new drug to our armamentarium. So I want to begin by just asking Neal and Dan to just comment on this article very briefly, and then we'll drill down into a couple of areas of the article. Neal, you want to begin?
Well, thanks very much, David. Yeah, on behalf of all of the authors of the HERO trial and all of the investigators and the families and the patients, we're remarkably proud and pleased to have accomplished a successful study. Relugolix, a once-a-day oral GNRH antagonist, is a unique development. We don't have any oral T-suppressive medications approved globally for our patients who are well suited for androgen deprivation therapy. And ironically, in the course of achieving this accomplishment, this happened and was published during one of the more profound pandemics of the last century. So of course, being able to take a once-a-day oral medication instead of coming into clinic to receive a parenteral administration for any oncologic agent, whether it's IM, sub-Q, or IV, certainly has obvious advantages for the protection for clinic teams, as well as for patients and their families. I do think, most importantly, this represents an oral formulation of a GNRH antagonist as opposed to an agonist for T-suppression. And David, you and I have been working on this for over a decade, and we've both been involved in the development of GNRH antagonists and multiple preparations and depot formulations of LHRH agonists. And I think it's always been very clear to you and I, and I'm sure to all others, that the mechanism of action of an antagonist is obviously more intuitive than the supraphysiologic surge one sees with an agonist. Now, that said, we've been using agonists remarkably successfully for decades, and it's a point of contention over the long period of a patient receiving an agonist versus an antagonist. Will it affect the disease biology and progression of the disease? And I think it's still an area of heated debate. What I'm most really happy about is seeing the pre-specified safety analysis in the HERO trial, which demonstrated a more than a 50% reduction in the risk of patients developing a major adverse cardiovascular event, or what we use the acronym MACE. And this is after, screening away for patients having had a prior MACE within 6 months to enrollment. And we still saw this marked benefit in the Relugolix arm versus the LHRH agonist arm. The field of cardio-oncology and our understanding of the importance of us all being better stewards of selecting therapies that have cardio-oncologic implications is very important in all aspects of oncologic care. And I think these findings are also that we demonstrated in HERO and published in NEJM is really very important for our colleagues to be aware of.
Thank you. Dan, anything you want to add to that?
Yeah, hi, David, and thanks, Neal. That was a really great summary. Let me just summarize the top level data from the HERO study, which again, I was really proud as Neal, to be part of an international study representing, Asia, Europe, United States, and North America, and this a large study, a 950 patient trial, randomized 2-to-1 to either Relugolix or leuprolide, and the primary endpoint of the study was to have a sustained suppression of testosterone of with a 95% confidence interval above 90% for Relugolix. And Relugolix actually more than achieved that. It had a 97% sustained T-suppression rate below 50, and the 95% confidence interval, the bottom level of that went down to about 94.5%. So a really tight confidence interval, more than met its endpoint. And then a key secondary endpoint was the non-inferiority to standard dosing leuprolide Eligard, which was provided on the study, dosed once every 3 months. And in that comparison, the leuprolide in that arm had a median, an overall average sustained suppression rate of 88%. And so not only was Relugolix non-inferior, it was actually superior, statistically significantly superior at suppressing testosterone. And then I think the other key aspect to this study, there was a sub-study built in to look at the testosterone recovery at the end of this 48-week period. And what we found was after 90 days off treatment, that the mean testosterone level in the Relugolix treated patients was 288 versus less than 50 still for the leuprolide arm. So really, again, showing a very statistically strong, quick recovery of testosterone, which has important implications for patients who are getting a defined period of androgen deprivation therapy.
Very good. Let me just follow up on that. What the testosterone recovery, is that good or bad or indifferent? As you mentioned, if somebody's on short neoadjuvant with radiation or something like that, it might be important. But I guess the downside of it is, and this is one of the concerns, that with a daily medication, if you miss it, that you're going to have some testosterone elevation. So what are your comments about that?
Well, I'll be happy to answer that. We give these medications for one reason and one reason only, right? Is to lower testosterone. And as we've all been aware over the years, it's ceaselessly amazing how often our colleagues won't even check a baseline testosterone before instituting a medication designed to lower testosterone. So that's an important point. I think having the ability to tightly regulate that goal, testosterone suppression, within the confines of picking a therapy is really important. The challenge historically with all of the parenteral agents is we never knew when testosterone recovery would occur. Some men would have their hypothalamic pituitary gonadal axis, persistently burned out even after 1, 2, or 3 administrations of a parenteral drugs of the various agonists. And this is a very devastating effect for many patients. I think we all recognize that patients are regularly asking after their testosterone is suppressed and they stop taking a parenteral medication, well, when is it going to come back? And the truthful answer is we just never really know with certainty. The on-off switch of this once daily medication, or Relugolix, clearly seems to demonstrate a much tighter control. And that on-off, I think, is an obvious clinical and subjective advantage for patients and for physicians. The issue regarding giving administration in a adjuvant, neoadjuvant fashion for intermediate and high-risk patients undergoing radiation therapy clearly just demonstrates the murkiness of understanding when T recovery even occurs. If one believes that more than 6 months is needed, then you should give more than 6 months, is how I look at it. Not kind of think, well, maybe I'm getting a little extra benefit if it lasts 7, 8, 9, 10, or 11 months or in perpetuity. You know, if that was your goal, then work within that mindset. So I really do think this gives us much tighter control, a much finer sensitivity to understanding what we're trying to achieve. Now, regarding the issue of compliance, David, it's a great question. Certainly, we've learned that the importance of compliance in our oral novel hormonal agents is important, and those are even more difficult to take. They're 4 pills, 4 capsules. Sometimes it's BID. Oftentimes, some of these oral medications need concomitant prednisone. The nice aspect to Relugolix is it has a half-life of 25 hours. So missing a dose, 1 or 2 doses, we have data that we will be reporting that it really is not a significant clinical event at all. But having said that, whether you're taking an oral medication for oncologic purposes or cardiovascular, lipid purposes, glucose control, compliance is of course important. And I don't think that's anything unique to a once daily pill such as Relugolix.
You made a lot of great points there, Neal. We know from prior studies, patients with cancer are more motivated also to take their drug than somebody that's lowering their cholesterol or blood pressure, things like that. You're a part of our presentation we did on late delivery of LHRH agonists, and 84% of the time it's not delivered on that 28 day or even a couple day holiday. The other thing, as you mentioned, is T recovery after radiation. I think I remember some reports from the bolus study, which was 3 years of hormones that very few people recovered. It was a slight one. So that's interesting. Let me ask Dan something. Is rapid suppression of testosterone? Our whole goal of ADT is lower testosterone, get it down and keep it down. Antagonists certainly seem to get it down quicker. I don't think we backdoor it with agonists. We raise it before it goes down. But at the end of the day, we've been surviving for the past couple decades on agonists, and as you mentioned, doing pretty well. And the average urologist, I don't think has major concern with flares. We try to play that for a while with anti-androgens. So what are your thoughts about how important is it for, really clinically meaningful for rapid suppression in somebody that has a rising PSA or, not having bone pain or urinary problems? So Dan, what are your thoughts about that? And then I'm going to ask both of you about adding an anti-androgen in a minute.
I think it's a great question. It's a great thought, because I agree with you. I don't think that's the number one differentiator clinically. For the 95% of our patients in the context that we're using our androgen deprivation therapies. But let me bring up a couple of scenarios where I think it is an issue. Really 3 scenarios. I think one scenario would be in patients that have, as you mentioned, symptomatic disease, urinary obstructive symptoms, bone pain and whatnot, suppressing that. We know that lowering testosterone can have immediate effects on pain, nociceptive effects on pain. So being able to lower that quickly can really help the suffering of our patients. With urinary obstruction, you got a Foley catheter in. The sooner we can get that working to get that out, the better. More importantly to me would be in the settings where we're combining our hormonal therapy with radiation therapy, where the goal is a relatively short course, 4 to 6 months of androgen deprivation therapy, not having to wait a month for that testosterone to come down, but be able to dose that immediately. Neal talked about it on the back end, but it's also on the front end. That control of testosterone can allow you to then administer your radiation therapy sooner, and then be able to really time that where you've got full synergistic effects of the 2 therapies together. And then the third scenario is something Neal alluded to early on, which was the cardiovascular differences. Because believe it or not, that testosterone surge could have cardiovascular implications. And when we look at the HERO study, at the timing of these major adverse cardiovascular events, we're talking about stroke and heart attack, the biggest separation in the incidence happened in the first 3 months, really even in the first month. That testosterone surge in some patients could be the tipping point of causing a cardiovascular or stroke event. So to me, and anybody that you're at all concerned about, even in the patients we don't know, maybe they just haven't had a cardiac workup. I mean, these are the patients I get a little bit nervous about. And we may not necessarily see them back in our clinic around that event. They're in the emergency room, they're in the hospital, they're getting worked up by cardiology. We're out of the loop on that. But at the end of the day, our therapy could be, maybe not in a lot of patients, but maybe in 2 or 3% of patients, the tipping point. And that 2 or 3%, if you're treating hundreds of patients a year with hormonal therapy, that 2 or 3% is real.
There are a number of good points. The one with radiation that goes back to John Blasco and some of the work he did with using agonists, and that you're actually wasting 6-8 weeks by, in prostate size increase, PSA, and so forth. And he actually showed that some of that could be ameliorated by using an anti-androgen. The surge is interesting too. And, it also fits in with some of the work we've done with late administration and acute on chronic, where you get flares. And, that may be one of the bad things that happens that raises your cardiovascular risk. And FSH is, as you know, we've had a lot of interest in that and in meetings. And that is also something that may play a role. This cardiovascular stuff with ADT, I think we sort of swept it under the rug for a long time. But the guy that deserves a lot of credit is Anthony D'Amico years ago, who brought this forward when none of us really believed it for a while. We knew about it with estrogens. So it's interesting. So what, anything else I'm missing, Neal, that we should cover here?
Let me just add, you're absolutely right about Anthony D'Amico, but frankly, David, your leadership and the work of, Andrew Shalley and how long you've been working at this and looking at the role of FSH and others, and Johannes Pinthus, and there's a lot of preclinical science and ongoing work that really, I think, culminates in the conclusions of the HERO trial. Prior review papers by Albertson published in European Urology, a recent phase 2 study done in Israel by Margell. So, I really thank you. You've been, at the forefront of for all of us, is trying to do better. How can we think about T-suppression strategies and the management of these patients? And I really would echo Dan's last point that, we take for granted a lot of these issues and cardio-oncologic effects, much like we did as it related to bone health. We would say T-suppression, frailty, fractures, skeletal related events. Well, we don't see it. Well, we weren't seeing it because they were being managed by our orthopedic colleagues and others and in emergency departments and hospitals. But not all patients will have cardiovascular issues, but certainly a very significant percentage will. As we showed in HERO that over 90% of the patients enrolled had at least one significant cardiovascular risk. Not surprising, this is an elderly population of men. In developed countries, they tend to have obesity issues, lack of exercise, other issues, dyslipidemia, hypertension, prior cardiovascular events. So, we really can do better. And I think that the proudest aspect that speaking for Dan and our other co-authors is bringing this education to the forefront. So, patients live longer and they live without complications of the therapies we impose upon them.
It's nice. Thank you for that compliment, Neal. And you're right. I mean, I think that we've known for a long time about cardiovascular risks are significant. We knew that with DES. And most of the events occurred early. We learned that too. And this study just reinforced that we've seen. And we've been fighting this and try to get some interest in it. And I'm glad to see it forward. And Yanni Pinthas, you mentioned him, has really been a workhorse at trying to identify this and looking at ways to avoid it. And it is risky. You know, you and I have both probably in our career have seen men that are older that we put on ADT and, you know, they have a heart attack and die at 6 months. We go, oh, well, just an old guy having a heart attack and died, but we probably assisted in their deaths. So I think this is great to bring this to the forefront and have something else in our armamentarium as we go forward. And I think we're going to learn a lot about the cardiovascular stuff and T-suppression and that all three of us have been pushing for a long time about, you know, what's the goal of testosterone's the king and we want to get it down. And that's what a lot of the drugs do. Any other comments, Dan?
No, thank you for having us, David. This was great. I would just say that, you know, when you're going to just think of this on every patient you're starting on androgen deprivation therapy, have you done an adequate cardiac workup? And are you using the safest drug available for that patient?
Yeah, and I think we just have to sort of risk stratify who we put on what and go forward. But anyway, thank you, and we look forward to having the drug available and hopefully approved very shortly. Thanks a lot, guys.
You're welcome. Thanks for having us.